Good evening to one and all. I am Dr. Sudhir Arava, Additional Professor in the Department of Pathology, AIIMS, New Delhi. And it's my privilege and pleasure to welcome you all on behalf of the Department of Pathology, AIIMS, New Delhi, today for our live webinar series named as Under My Scope. Today, we have interesting and interactive discussions on the subject of dermatopathology by two well-known, eminent, and dedicated faculties in the field of dermatopathology, that is Dr. Manoj Kumar Singh and Dr. M. Ramam. Dr. Singh and Dr. Ramam do not need any introduction for those who are attending the dermatopathology conferences and teaching courses in India. For those who do not know them, Dr. Manoj Kumar Singh is currently a professor and head, Department of Pathology, All India Institute of Medical Sciences, New Delhi, and Dr. M. Ramam is a professor, Department of Dermatology, AIIMS, New Delhi. Both are founder members and past presidents of the well-known and active society known as Dermatopathology Society of India, that is DSI, which was established in 1997. Their main motto is to teach and disseminate knowledge in the field of dermatopathology. Both have numerous publications in national and international peer-reviewed journals. Without wasting time, I welcome Professor Manoj Kumar Singh and Professor Ramam to this academic feast. Sir, we are delighted to have you with us to participate and share your experience knowledge in the field of dermatopathology. A small remark to all the participants. Any questions and queries may be typed in the chat and send us in the live YouTube channel. All the relevant queries will be answered and discussed at the end of the webinar. Now, I request Professor Manoj Kumar Singh to start and take over today's JugalBandi in dermatopathology. Sir, over to you.
Thank you, Sudhir. Host has stopped it.
Yeah, please allow him to start his video.
Share screen. Thank you, Sudhir. Ramam and I, for this type of exercise, coined the term JugalBandi many years ago. And definition I looked up recently because one of our colleagues who was organizing this said that there'll be many people who might not understand what a JugalBandi is. So, as per the dictionary, it's a word in Hindi or Urdu, of course. In Indian music, a duet involving two musicians. And also, part of the definition is that non-musically, the term has been used in many interesting ways. This is one of the ways in which we have used it. I would like to ask your pardon in the beginning only because Ramam and I may be interrupting each other, perhaps even arguing with each other during the discussion. Please forgive us and consider it the bickering of two old men who have been friends for a very long time. Ramam.
Okay. So this first case that we are going to discuss with you is of a young woman. She presented with a shower of erythematous and purpuric papules on both lower legs for about 10 days. She had no other symptoms, and a biopsy was taken from one of the fresh red papules. Manoj.
So what we see here is essentially on the low power, we see that there is some inflammation, perivascular, as it always is in the beginning. And also you see a lot of RBCs. Now RBCs present in the dermis like this, The first thing which one thinks of course, is traumatic biopsy. But here you can see that there are RBCs in a few areas and none in the other areas of this biopsy. And now if you see here, you can also make out that this capillary wall is compromised. It is showing some kind of a fibrinous deposit, and a little better seen in these two. This is a fibrinous degeneration of the capillary walls, which means that there is an active inflammation going on here. Now, this type of cutaneous vasculitis, also known as leukocytoclastic vasculitis, because you see leukocytoclasia here, is in many cases it is the pathology or the etiopathogenesis is not understood, and people have tried to do immunofluorescence in this. We have also, and in a case of LCV, we have very seldom seen a positivity. The issue is that if an antibody has caused this, it gets consumed very rapidly by the inflammatory reaction. And some people have commented on the immunofluorescence. And here you can see that perhaps there are a few positives, maybe anti-nuclear factor positive in these cells, and indicating to us that one of the causes is lupus erythematosus. And it could also be IgA. We have very, very seldom demonstrated these.
So for case 2, I'm going to show you 2 patients. One had this erythematous scaly plaque with central clearing on the foot. And the next patient has this hypopigmented large macule with ichthyotic scaling and hair loss. Both had prominent sensory loss in the lesions that they were aware of and they complained of, and which we were able to document with sensation testing. So naturally, the first thought is that, is this leprosy? So this is the Ridley-Joplin classification of leprosy, and it shows you the spectrum ranging from tuberculoid leprosy to lepromatous leprosy. And we'll also talk a little bit about neuritic leprosy. Manoj.
In this biopsy, as you can see, there is a dense inflammation in the epidermis here and perifollicular here. And this appearance, which we'll see a little more well-defined in one of the later slides, is a characteristic inflammation surrounding the vessels, and this is known as a coat sleeve, because that's what it looks like, an arm inside a coat sleeve. But here you can make out something else which is very interesting. You see that these cells in the center are different from the lymphocytes around them. This is in fact a granuloma. These are epithelial cells, and they are rimmed by a large number of lymphocytes. And you can make out this appearance, and this appearance is actually fairly characteristic. And we at times see the slide as a spotter, and we say this is leprosy. And it does turn out to be tuberculoid leprosy. 2 features need to be seen. One is, of course, there is a granulomatous inflammation, very extensive granulomatous inflammation, scant necrosis. In some cases, you may have necrosis. I'll tell you about them a little later. The other very important feature is the involvement of the appendages. The smooth muscle here is involved. Here you can make out that the sweat apparatus is involved by the inflammation. And at times you do see giant cells. So some people have opined that you do not see giant cells. You do see them occasionally, because the giant cell is part of an epithelial cell reaction. But what you do see characteristically in leprosy is nerve involvement. And this is something which we go out of our way to look for, because these are minute cutaneous twigs, which you may not even notice in some other biopsy. But here you can make out that this nerve twig has inflammation on one side, And if you see a more involved nerve twig, well, we'll come back to that. You will see that this is also inflamed. The nerve fiber itself is disrupted. There is edema, and there are inflammatory cells. So this, I would have no hesitation in saying that this is a tuberculoid leprosy. And between the two ends of the Ridley-Jopling classification, this is the upper end. TT and BT may at times be difficult to differentiate. BT is extremely common. TT actually we see not so commonly.
Yeah, I completely agree with those comments, Manoj. There seems to be some difference in how different departments use the term tuberculoid and borderline tuberculoid, because there are some people who diagnose tuberculoid quite a bit, but you're right, we hardly ever label anything TT. Maybe we are using too strict criteria, and most of the time we are calling it BT. But when it comes to looking at it under the microscope, there is, in practical terms, very little between the two. So BT-TT is a perfectly acceptable diagnosis for us. Thank you. So the next case is this man who had multiple annular plaques of varying sizes on the lower back and trunk. And we're looking at the other end of the spectrum now. I'll show you another example of a patient at this end of the spectrum. This is somebody who has multiple shiny skin-colored nodules studding large areas of his skin. And when you take biopsies from either this patient or the last one, what you see will be described by Manoj over the next few slides.
And here we have, again, a dense inflammation. But if you see this, even on the lowest power, you see that there is atrophy of the overlying epidermis, because these are expansile nodules stretching out the epidermis on top. And the number of lymphocytes is much less compared with the tuberculoid leprosy we saw. These are, in fact, light-colored cells. And as you can see here, these are foamy cells. The Grenz zone, which is the zone below the epidermis, is well maintained. And again, this is involving or surrounding the appendages. This is surrounding the sweat duct apparatus. And very beautifully you can make out in this slide, as opposed to the nerve twig that we saw there, which was actually inflamed. There was inflammation around it and inflammation going into it. There was active neuritis. You can make out these two nice nerve twigs, which actually are not so involved with the inflammation. They are surrounded on all sides by the inflammation or whatever this gathering of cells is. And at the high power, you can make out that this is also a fair number of lymphocytes are there, but they seem to be destroying the nerve a little less than they were in tuberculoid leprosy. Again, showing you that many of the cells are foamy. You can make out that these are bluish material which is present inside each of these foam cells. And if you do a Ziehl-Neelsen stain, as expected, you see that the cells contain acid-fast bacilli, and this is a Lepromatous leprosy, BL or LL. Now, LL is much more common than actually a diagnosis of TT in our center. We do see many cases which are labeled by the clinician as LL and BL also. And I'd just like to show you this. This is one of those cells containing a dense aggregate of acid-fast bacilli. This is the auramine rhodamine of one of these cases, showing you on fluorescence this yellowish or greenish yellowish positive fluorescence. This cell, which contains a large number of acid-fast bacilli, is looking like a signet ring cell, which you see in other cases. And this is called a lepra cell. So this is a case of Lepromatous leprosy.
So if you could just leave the slide on for a second, the last one. The one after this. Yeah, thanks. So we said that BT and TT, it probably is pointless trying to differentiate. But BL and LL can look a lot like each other too in the number of foamy histiocytes and the AFP. But there is one important difference when you look at these slides, and that is that BL has a large number of lymphocytes and LL has far fewer. So histomorphologically, you can tell the difference. And as I showed you at the beginning, those two cases do look different from each other. BL can go on to LL, and that's sometimes called LLS. Okay, moving on to case 4. This is pretty challenging. You know, when some dermatologist sees a presentation like this, the differential diagnosis is quite broad. You know, it would include fibromas, dermatofibroma, histiocytoma, even molluscum contagiosum and leiomyoma. And if you really wanted to stretch it, you could even include histoplasmosis or sarcoidosis. When you have a few or multiple nondescript, skin-colored, dome-shaped, small papules, then making a firm clinical diagnosis is pretty tough. When we take these biopsies, we are looking for help from the pathologist.
And this low power, of course, hasn't helped the clinicians too much, because it shows fascicles, interweaving fascicles of cylindrical cells. All these are bundles below the epidermis. Here you can make out again the Grenz zone is somewhat preserved, but throughout the dermis you have these bundles of cells, which on high power again. Now these are not looking like the foam cells, but definitely all these cells are very pink, light pink in color. And in fact, you can very nicely make out that also there are a sprinkling of lymphocytes. Again, you see the same things here. So you don't see the lepra cells, but these are light pink staining aggregates of cells, again in fascicles and bundles. And when you look at it in the high power, you may see 1 or 2 foamy cells, but the majority of cells are actually, you know, there are cases where you might even think this is a fibroma or a leiomyoma or something like that. But of course, when you do an acid-fast stain, this is a very, very rich collection of acid-fast bacilli inside the cells. And this, as you might like to compare this one of your with the earlier slide, these are predominantly intracellular bacilli. And here in this stain, you can make out that there are some cells which look like the lepra cells which you saw in the earlier biopsy, but majority of cells are actually not foam cells. And this is a characteristic of this particular type of leprosy, because this contains a large number of acid-fast bacilli inside the cytoplasm of these histiocytes, but very few of them actually look like lepra cells. And here is a high power of the same. You can again, as I showed you in the Lepromatous leprosy, the appendage, the smooth muscle is surrounded by the inflammation, but not destroyed the way it is in tuberculoid leprosy. And in the high power, you can make out that many of these cells are actually present singly inside the cells, and there are 1 or 2 collections also. So this is a variant known as Histoid leprosy, and this is a variant of Lepromatous leprosy. Ramam, would you like to?
Yeah, sure. Thanks for stressing the point that you have to see spindle cells on the biopsy in order to make a diagnosis of histoid leprosy. There are times when clinicians will see nodular leprosy, and because the nodule is small and shiny, mistake it for histoid leprosy, and then they're very disappointed when they get back a report of LL and not of histoid leprosy. And the reason is that unless there is a spindle cell morphology, you shouldn't be calling it histoid leprosy. So that's one thing. The other thing about histoid leprosy is that there are 2 settings in which you get this clinically. One is somebody known to have lepromatous leprosy who has some histoid lesions. And in that case, it's easy to make the clinical diagnosis, and that alerts the pathologist, and the circle is completed. But there are times when people present with just a few of these histoid lesions, not known to have leprosy, and the clinician can be in a fix, and his differential diagnosis may include spindle cell tumors. And then if you're not careful and you're not looking at it closely, it might get even passed off as a spindle cell tumor, so that then you don't do the AFB, and so you miss the diagnosis. And we've known that to happen. And then when those cases were reviewed in our department, the histoid leprosy was picked up. So be careful when you see a spindle cell neoplasm in the dermis. Keep histoid at the back of your mind and see if it fits in with the clinical and the histopathology. The next case is one that is a challenging presentation for dermatologists. This is a patient with sensory loss on the hands, and look at the muscle atrophy. The thenar muscles are completely atrophic. And this is because he has a neuropathy, which is leading to sensory loss on the hands and the muscle atrophy. There are no skin lesions at all. Some nerves are thickened and slightly tender, and we call this neuritic leprosy. Or if you're a purist, some people call it primary neuritic leprosy because he may develop skin lesions later on. But when there are no skin lesions, it's very difficult to get tissue for a diagnosis. And sometimes we will biopsy a superficial nerve in order to document the diagnosis. And usually the radial cutaneous nerve at the wrist is the one that we pick, because the sensory loss that results from cutting that nerve is limited only to the anatomical snuff box. And so that's a situation in which you might get a nerve biopsy from a dermatology department.
And as Dr. Ramam had pointed out, when you get a nerve biopsy, the diagnosis is pretty well known. And as I had tried to show you in the tuberculoid leprosy slide, this nerve is not only surrounded by inflammation, it is also heavily infiltrated and inflamed by itself. You can make out these lymphocytes here. In the high power, you make out this so-called neurofibrillary background, which is a wavy kind of an appearance. And you can make out that these are the inflammatory cells present in the nerve. The nerve itself is getting destroyed. And that is why there is the nerve symptoms. Again, the same thing, background and inflammation, destruction of the nerve. At times, there may actually be necrosis, as you can make out in this particular case, that inside the nerve substance, possibly because of compression, because of the expansile nature of the inflammation, there are areas which may be necrotic. This is a rarity in leprosy. In the spectrum of leprosy, this inflammation you don't see very often, even in tuberculoid cases. And here you have this myxofibrillary background, bluish stain, showing you that this is myxoid material. And in the S100 stain, you can make out that there are some remaining fibers in this area, but the majority of it is actually destroyed. As you can make out here, majority of the nerve itself is destroyed, and some part of it is, some fibers remain.
So, Professor B.K. Girdhar, the late Professor B.K. Girdhar, did a lot of studies on neuritic leprosy, and he demonstrated that you get the whole entire spectrum of leprosy in the nerves too, from tuberculoid to lepromatous, and Manoj has just demonstrated some of those findings. Okay, so we're now switching to an entirely different set of disease. Now, again, I'm showing you two patients here, two different patients. One of these has a lesion on the face. He has an annular erythematous thin plaque with a serpiginous margin. The foot lesion is not quite annular, but it does have the same serpiginous margin. If you can see, the junction between the normal skin goes in and out. It's not smooth. Now, tinea or dermatophytosis, erythema annulare centrifugum, granuloma annulare, annular lupus erythematosus, and annular lesions of leprosy would enter the broad differential diagnosis of annular lesions in the skin. Let's see what a biopsy from this patient shows.
And here, of course, the clinicians, though we keep asking them for it, very seldom biopsy this case, because when you do have a biopsy, you have something very interesting. You have hypoplastic epithelium here, epidermis. This is a higher power of the same. And if you would compare this particular downgrowth of the epidermis or ridge with this area, which is possibly a follicle, you make out that there is some difference between this and this. And what is this difference? I removed that slide. Well, I had a higher power of this. And you can make out that here there are many, many round structures staining bluish here. And these are fungal hyphae in on an HND stain. And this is why we don't very often get biopsies of this, because in the OPD, the clinicians make a scrape and treat it with a little potassium hydroxide, and they see the fungus. So we have to, in fact, ask them, please biopsy a couple of cases. We'd like to see what the fungus looks like on HND. So this is what this is. This may involve any part of the body. And
the next few slides are actually clinical examples of some other superficial fungal infections. This is somebody who has glazed erythema and maceration in the skin folds. You know that the wet keratin looks white, and there's this slight fissuring, redness, pustulation, which is characteristic of superficial candidiasis. The next set of pictures shows boys with patches of alopecia, where there is also scaling and in one instance swelling and redness. So this is a non-inflammatory and inflammatory tinea. And the last example of a superficial fungal infection is candidal paronychia here, where the candida is actually in the nail fold. And because the nail fold is where the nail is manufactured, inflammation of the nail fold leads to a secondary dystrophy. So this is not really a onychomycosis in the sense that the nail is not directly affected by the fungus, but it's a secondary nail dystrophy because you're getting candidal paronychia. So the treatment is not of the nail, but of the nail fold.
And these are the various different names given to this disease, depending on the site of involvement. And here, again, you can make out that in this follicle-like lesion, there are multiple bluish staining structures. Here, you can make them out a little better. Vacuolated structures, vacuoles. And if you do a PS reaction, you can in fact make out that in the keratin you have these fungal hyphae. The same thing actually. I thought I had a silver methanamine of this also, but you can make out that these structures on the PS reaction show the hyphae, and you diagnose this. At times, the clinicians may even see this on a scraping, though the epidermis needs to be teased out properly.
Right. So, just wanted to make the point that when clinically we suspect tinea, as Manoj mentioned, we don't biopsy it, but there are times when we miss the diagnosis, often because the patient has been applying corticosteroid creams and the presentation is difficult to recognize. It goes by the name of tinea incognito. And in those situations, we might take a biopsy thinking it's one of the many other annular lesions that we talked about or something that is scaly. like a dermatitis, and then it's your alertness and your ability to pick up the fungus at the microscope that then helps us to give the patient the proper treatment. Okay, so this is a mycetoma. There's a swelling, there are sinuses and discharge from the sinuses. Some patients notice grains, others do not. Here, when we take a biopsy, we have some rather specific needs. It's not so much diagnosis because kind of we're able to make that most of the time. But what we want to know is whether a grain was visualized on biopsy and if the grain is fungal or bacterial. And since finding grains is a bit of a hit and a miss, in our department, we take 3 biopsies straight up from the patient to improve our chances of finding the grain. And so usually we send A, B, and C of every patient with mycetoma so that a grain can be visualized.
Something which I have been requesting for a long time now, but due to shortage of time, it's not possible to, many times it's not possible to admit a patient and treat him or her to what has been called the bandage biopsy. In other words, you put a moist gauze piece on top of this, bandage it up, and leave it for 48 hours, 72 hours without too much disturbance. And at times, when you take off that gauze piece, you may in fact see a granule, which you tease out on a slide and you can study it. And as what Dr. Ramam said is very true, in that this is a long-standing lesion. Though a biopsy from one of these necrotic areas, these areas, would actually show you hemorrhage and inflammation. It may not show you a granule which is characteristic. A biopsy from one of these areas will show you a foreign body reaction and will show you chronic inflammation. And at times, even with 3 biopsies, one is lucky to see a grain or a granule in the biopsy itself. Here you see a biopsy. This is showing you this dark-colored mass, and these are again something which in this particular biopsy there were large numbers present, so we were able to demonstrate it nicely. And this, as you can make out here, a higher power and an even higher power. Here you can make out that these are in fact hyphal profiles. These are in cross section, so they are looking round. There may in fact be here somewhere an elongated profile also. And people have done a lot of work in this. This is a very common, not a very common, but it's a common condition in our humid areas, in the northeast, some parts, and in the south. And I presume the same in Malaysia and so on. And some people have tried to classify by the color of the granule. This actually should be not red discharge, but a red granule. And some people have tried to classify, but then there is such a wide spectrum in the black granules or the white or yellow granules that this is more exercise of completion rather than diagnostic help. And as Dr. Ramam had earlier said, this was a fungal granuloma, and this is properly called a eumycotic mycetoma.
Just to reiterate, even if we send the biopsy with a diagnosis of actinomycotic mycetoma or eumycotic mycetoma, please ignore that completely. There's no way a clinician can tell whether he's looking at a bacterial mycetoma or a fungal mycetoma. And when you have a biopsy, if you don't see the grain, please say so in your report and add a note saying that you cannot tell if it is a fungal or actinomycotic mycetoma without the grain. Remember that the reaction pattern is exactly the same in both kinds of mycetoma, but the treatment and prognosis are completely different. And so please make sure to mention in your report whether you saw a grain and whether it was actinomycotic or eumycotic. And fortunately, the difference between an actinomycotic grain and a eumycotic grain doesn't depend on us knowing the morphology of each of those several organisms that Dr. Manoj showed you just now. All that you have to look at is the caliber of the filament in the grain. If it is thin, about 2 microns, then it's an actinomycotic grain. If it is thick, 5 microns or more, then it's a fungal grain. And telling us whether we are dealing with a fungal mycetoma or an actinomycotic mycetoma is the critical element of a biopsy report. So please do remember that when you're evaluating these biopsies. And if you don't see a grain, put a note, no grain visualized.
And here, what Dr. Ramam was pointing out, you see that compared with the other ones, which I had listed out also as a red grain and a white grain and so on, this is a blue grain. And if you see in the high power, you don't see those fungal profiles, the 5 micron things. These are in fact fine fibrils. And these fine fibrils are actually the bacterial colonies. Many bacteria may be involved in this. The prototype is Actinomyces israeli, and this is a PS reaction. Again, showing you that there are no fungal profiles seen in this. You can make out that these are fine structures, filaments, and this is classic of an actinomycosis. The point to be noted is, of course, that we have a very active and effective department of dermatology in our institute, because there are a lot of places where actually the treatment which is offered to these people is some kind of an amputation, because this being a chronic inflammation which goes on for a long time tends to go deep, tends to involve bone, tends to involve the deep tissues, and perhaps in the absence of proper chemotherapy, an amputation is the only thing available to those doctors. For us, fortunately, that is not so.
Yeah. Again, to reiterate that, amputation, I mean, I cannot think of a situation where one would think of you undertake an amputation. So again, please discourage anyone who's planning an amputation for a mycetoma. I think that's a treatment of the past. And there are very effective treatments available for antimycotic mycetomas and for eumycotic mycetomas. Treatments are reasonably good, not as great as in a bacterial mycetoma, but surely, yes, good enough that we can avoid a amputation. Thanks for bringing that up, Dr. Manoj. So this is a little bit easier, we've been talking about some pretty complicated stuff so far. But these patients might present with situations that fox the clinician, but may give deep satisfaction to the pathologist when he looks at the biopsies. Now, this patient on the right has these shiny papules on the penis, and lichen nitidus was suspected. And this patient on the left is an HIV positive patient. She had multiple papules, and so because of the setting, we thought, could this be histoplasmosis? Could this be cryptococcosis? Or was this just a wild case of Molluscum contagiosum? We weren't very sure. But both these patients were biopsied because of the doubt in the diagnosis.
Punctate papules.
Yeah, early punctate papules.
And here, of course, there is no doubt about the diagnosis. You have this down dipping, huge hypoplasia of the epidermis, and as you can make out here, this is in fact staining a little more bluish than the normal epidermis here. You can make out a little better here, and in fact, there seems to be some kind of a maturation going on. And if you have a deeper cut of this, you might see this coming through to the epidermis. And this, in fact, is the punctum I was pointing out earlier. These, in fact, are grossly distorted epidermal cells, which are stuffed full of some material. And what is this material? You can make out from the outside. This is bluish material in the cytoplasm, which here is becoming aggregates of keratohyalin, a little higher power showing this. And these are the little things which will discharge through that punctum. And these are, in fact, known as molluscum bodies or Henderson-Patterson inclusions. These aggregates of keratohyalin, which grossly distend the cell, and that gets eventually thrown out to the outside and is infectious from one person to another, or from one site in the same patient to another site. So these may spread the infection from one to the other.
Okay. Just a quick remark that molluscum, if we make the diagnosis clinically, we don't usually biopsy. So there are times when we have missed the diagnosis clinically or wanted to make sure that it was indeed molluscum and not something that looks molluscoid, especially in an HIV or immunosuppression setting.
Actually, if you do not biopsy a molluscum, your pathologist will never forgive you, because it's such a pretty lesion.
So these are two different patients. The one on the left is a young man who presented with multiple hypopigmented thin plaques along with hyperpigmented plaques. You can see both of them on his all over his body. His brother had similar lesions. So this is a rare disease. Actually, it's a very rare manifestation of a common agent. And the guy on the right is also a young man. He presented only with the hypopigmented papules. Notice that he doesn't have the hyperpigmented papules and plaques, which the guy on the left has, and some of which are closely aggregated. The guy on the right has hypopigmented papules close, and there is Cobner's phenomenon, which is the linear array of papules around his umbilicus. So that's what these guys presented with, and we took biopsies of the hypopigmented lesion as well as the hyperpigmented lesion in these patients.
And this, of course, at times may be a difficult diagnosis, because this is a very, very obvious biopsy and an obvious clinical feature. At times, you just see a normal epidermis like this. But here, you see something else. You see these bluish stained cells in the epidermis. These are epidermal cells, but they have this bluish color to the cytoplasm on normal HND, which actually should be pink color like this. And what are these bluish cells? You can also make out in some areas, like here, there is an increase in the number and size of the keratohyalin granules. So this is nothing but papillomavirus of the skin, and this usually presents to us to the clinician as a wart, a viral wart, and many times they don't biopsy it at all. But this manifestation is unusual, and it is reflective of a slightly different clinical scenario. Ramam, would you like to? This condition is known as Epidermodysplasia verruciformis, a very descriptive name. Ramam?
Yeah, it's a genetic susceptibility to human papillomavirus. So they have multiple lesions all over the body, and that's why one of our patients' brother also had the same disease. And just to be clear, sometimes trainees, residents will ask us whether these are coilocytes. They're not coilocytes. So coilocytes have puckered, raisin-like nuclei and vacuolated cytoplasm. Here, the keratinocyte is enlarged. It's stuffed with grayish-blue cytoplasm, and the nuclei are also often quite enlarged and vacuolated. So very different from coilocytosis, though the cause of coilocytosis and this EDV cell is the same. It's the human papillomavirus. There are certain types of human papillomavirus that are associated with this Epidermodysplasia verruciformis change. Okay, moving on. This is a 55-year-old woman who presented with multiple itchy erythematous plaques and large, dense blisters, which are both clear. As you can see, some of them are filled with clear fluid and others are filled with hemorrhagic fluid. When we choose to take a biopsy, we look for a small, fresh blister because these are long-standing. These have been there for about 7 or 10 days and don't make for good diagnosis. So we try and look for a tiny blister that is new and we try and take it whole. And then we take a biopsy from the perilesional skin for DIF. And that's what we did in this patient and sent those biopsies off to Dr. Manoj.
And this is, of course, a very characteristic appearance on the biopsy. This is, as Dr. Ramam pointed out, a very nicely taken hood lesion was biopsied. And you can make out that this split between the dermis and the epidermis is starting here and has become complete here. And if you trace it a little bit on this side or this side, you may see normal epidermis. And what exactly are you seeing here? You can make out here that the epidermis seems to have split off in its entirety. You can make out that here you can make out the basal layer of cells. Now, a purist may ask, what is this doing here? This is not epidermis in its entirety. And this probably is a single layer of cells. We'll talk about this in the next few slides. This is a few cells which are here. So this actually means that part of the epidermis has been left back, but the majority lesion is here. And this could be biopsy trauma or an artifact caused by the blister itself, that so much of the epidermis has actually come off and another part is kind of joining it. This is actually the classic lesion here. And when you do the immunofluorescence, of course, you know what you're looking at. IgG, linear deposit at the level of the basement membrane. And the same you will see for C3. And at times, you will see the same for IgA also. Now, Ramam, would you like to just talk briefly about the IgA variants? Or just, okay. IgA may be seen, actually there is a condition described as IgA Bullous pemphigoid, but IgA is seen actually not in this linear fashion, but in a granular pattern in some of the other conditions which are IgA dermatosis also. And if you have this linear pattern, then you are a little more certain that this may be Bullous pemphigoid.
Yeah. So classically, IgG linear Bullous pemphigoid, IgG and C3, and linear IgA is linear IgA dermatosis. In children, we call it chronic bullous dermatosis of childhood. And when it's granular, then it's probably dermatitis verruciformis. And it can be tough for a clinician to decide whether he's looking at bullous pemphigoid or linear IgA dermatosis. So DIF does help to sort these things out. This is our next blistering disorder. And this is a younger person. This is a young man with both oral erosions and blisters on the skin. I think these are two different people, but for illustration, I think we can think of them as being of the same person, because often patients will have both. Most patients begin with oral erosions and then a few months later will develop these flaccid blisters on the skin. And these are easily eroded blisters. So they differ from the blisters we saw just now, which were large and tense and both clear and hemorrhagic. These tend to be flaccid and easily eroded and often accompanied by oral erosion.
And here again, you have these another split in between the dermis and the epidermis, but here there is some slight difference. You can make out that throughout the dermis, above the basement membrane, one or two layers of cells are intact, and the split is actually happening above these basal cells. And you can make out, as you know, the epidermis is in a state of constant tension. The hexagonal nature of the epidermal cells is because they pull each other apart and also pull the dermis. So there is this dynamic structure of the skin. And when this adhesion is lost, as it is here, then the dermal papillae tend to protrude into this bulla cavity. And there are two terms which are used to describe this particular morphology. As you can make out here, this resembles gastrointestinal biopsy in that there is a villus which is protruding into the cavity, intestinal or bulla cavity, and also here. As you can make out, these are the villi, and here you can very nicely make out that there is a single layer of basal cells which are in fact again protruding into the cavity and separated from each other. Now this is a peculiar artifact which is caused by this condition. This is Pemphigus vulgaris, and in this the dissolution occurs of the cell-to-cell interaction of the epidermis, and these cells not only shed off the epidermis, but the basal layer cells are attached in a different fashion to the basement membrane. So the basal layer cells themselves are kind of separated from each other, but attached to the basement membrane, giving this the appearance of a row of tombstones. And this is the other classic description. So this is a villus, and this is a row of tombstones, rounded off cells. And the other feature, of course, is you see, if you make a smear of this, you will see similar cells, epidermal cells, which are shed off into the bulla cavity and rounded off because they lack the dynamic tension. These are the so-called Zank cells. And the smear which is made is called a Zank smear. The row of tombstones, which you can make out here. And when you do the immunofluorescence, you can make out nicely that this row of tombstones, the cells are surrounded by IgG. And IgG usually, there may be other antibodies also, but usually this is, in the majority of cases, pemphigus is caused by IgG, which can be identified. And this is not basement membrane the way you saw in bullous pemphigoid. This is in the epidermis. And similarly, this is a fragment which is shed out into the bulla cavity. These are the individual Zank cells. Each one of these is surrounded by IgG positivity. Ramam?
You want to talk about your work on DIF on Zank smears?
We'll do it again. Yeah, I mean, we'll take another session if our organizers will permit.
Right.
We have a lot of such sessions.
Right. Okay. So the next case is Pemphigus foliaceus, which is a much more superficial split, and Dr. Manoj will describe what you're seeing in these biopsies.
Well, essentially, there are 4 variants of pemphigus which are described. The 2 at the suprabasal level, the split at the suprabasal level, are Pemphigus vulgaris, which is by far the commonest, and Pemphigus vegetans. But there are other variants where the split may occur much higher up in the epidermis. Here, in fact, at this magnification, you feel that this may even be a normal skin biopsy. But you do see some peculiarity going on here. And when you see this, you can make out that the basal layer and the lower part of the epidermis is pretty normal. But what's happening is right up in the subcorneal location here. And again, these are Zank cells which are forming. Individual cells are shed off into the bulla cavity. And because this is such a thin covering on top, which is only actually at times the keratin layer, many times you don't see the upper part. You see only the epidermis and these few changes which you see here. And you would note also, as Dr. Ramam pointed out, in bullous pemphigoid, because the entire epidermis is forming the roof of the bulla, it can take a lot more pressure, structural integrity is there, and you have tense bulla. In Pemphigus vulgaris, the bulli rupture very early. In Pemphigus foliaceus, in fact, you at times might not see a bulla at all. And here you can see, again, that the involvement is right up there in the uppermost part of the epidermis. And you see what Dr. Ramam had said about the adjoining area. You make out that there is IgG positivity in the epidermal cells. Here, nicely, this is called the fishnet appearance of positivity. Pemphigus foliaceus.
So this is somebody who has hyperpigmented macules close to each other in the flexure, in the axilla in this case. We also have it in the neck and the groin. And the older name of reticulated pigmented anomaly of the flexures kind of captures better how these people present clinically. It's also called Dowling-Degos disease, and which is the diagnosis that we made, and we sent these biopsies for evaluation.
Again, a very pretty picture. You make out these downward serpiginous proliferations of the retipegs or retiridges going into the upper part of the dermis, and it's a fairly characteristic appearance when you see it. And these are hyperpigmented. This is why those papules or larger papules are in fact hyperpigmented, because there is hyperpigmentation in the lower part. Here.
So this is somebody who presented with annular plaques. This is the definition of annular. You have a narrow rim of raised skin right at the periphery and a clear center. The other thing, if you blow up these lesions on your screen, you can see that they are, apart from being annular, the border is beaded also. And this is very characteristic of a condition that we call granuloma annulare. And in this instance, because it's mostly on sun-exposed skin, we call it photosensitive granuloma annulare. When it's not quite as perfect as this, then the differential diagnosis includes many of the other annular conditions that we described when we were talking earlier. And that includes erythema annulare centrifugum, dermatopathology, annular leprosy, annular drug eruptions. So it's a wide diagnosis. But in this, we were pretty sure that we were looking at granuloma annulare because of the morphology of it.
And in granuloma annulare, as is evident in the name, there are granulomas, and it is annulare because of the annular appearance of the lesions. But what actually happens here? What happens is this characteristic collagen necrosis. As you can make out here in this higher power, even you see here there is inflammation going on here, and when you see here, there is this characteristic breakdown of the collagen which evokes an epithelioid cell reaction to itself. And granuloma forms, and at times there are clinical situations and histological situations where somebody might mistake this for a tuberculoid leprosy. But here you can very nicely make out that these are the collagen fibers which are undergoing degeneration here, and they are surrounded by the epithelioid cells which have formed as a reaction to this. In granuloma annulare, the leads to this, of course, is this interweaving of the inflammation and the necrotic fibers, and at times when you do an Alcyon blue PAS, there is this marked increase of the ground substance. This is again part of the collagen degeneration, which you see in a granuloma annulare.
Okay, Manoj, you asked me to tell you when we were at the 1 hour mark. So we are there now.
We'll do a little more. I think,
let's do
Ramam, we'll talk about this one.
20 and then stop. We are at case 17 now.
We'll do up till 19 and then we'll go to the last case.
Okay, fine. So let's do case 17 now. And this is, when you have these papules, and this is, of course, Cobner's phenomenon on the dorsum of the hand, this linear lesion. We talked about that just a little bit ago. But more importantly, if you look at the individual papules, each of them has a central plug. So in this setting of a young person who has centrally plugged papules on the dorsum of the hand, this appearance raises the possibility of a perforating disorder. And we always like to have that documented on histopathology. That's why we took a biopsy from one of these papules.
And precisely as Dr. Ramam described in the clinical feature, there is what he said was a plugged papule. And here we have this mild epidermal hyperplasia and this large material which is gathered here. Obviously, this is inflammatory oblique necrotic, higher power of the same. And here, in fact, you see something is happening here which is extruding into this material. Can you make out this? And this becomes the punctum or the plugged punctum. And something else very interesting, a feature which we have remarked on this, a higher power of the same, showing you that there is granulation tissue at the base. And this is a special stain. And this is a Masson strichrome. And here you see something very interesting. This is the that necrotic material. And this is the area where something is coming. Here you have the epidermis, which is intact. And here you have the dermis itself, which seems to be undergoing this necrosis. And in this higher power, you can make out this very, very pretty feature. This is a collagen fiber, similar to these other ones which make up the structure of the skin, which is necrotic. It has gone into this necrotic material. And you see this material which is inflammation and necrosis, and also viable or semi-viable collagen fibers. And this is another collagen stain. Again, you can make out the same. In a BVG, you can make out that these are kind of intact collagen fibers like this one, which are going into this material. And this group of disorders has in fact been clubbed together as T, disorders of transepidermal elimination. And this includes several conditions in it. Perforating folliculitis, perforating dermatosis, reactive perforating collagenoses, elastosis perforans serpiginosa, and so on and so forth. And possibly I know as little about the pathogenesis or etiology of these conditions as Ramam does. So we will not talk about that too much. But in transepidermal elimination, it is important to look at what actually is the material which is going out. When is this kind of a material, this is actually a degeneration of the collagen, of the dermal collagen, which is being eliminated. But there may at times be something which you can recognize. Now, what are these conditions? If you have a calcinosis cutis, which is formed here, calcium may be extruded in this fashion. And if it's a foreign material which is embedded here, this may be extruded in this fashion. So it is important to look here. You don't very seldom find anything except this very pretty feature of collagen being degenerated and going up. Ramam, anything? This PF incidentally is perforating folliculitis, not Pemphigus foliaceus.
That's right. Right. So our Next case is, this child on the left has ichthyosis with very prominent pigmented varicosity. And this pattern of ichthyosis suggests epidermolytic ichthyosis. And on the right, we have a very typical presentation of a verrucous epidermal nevus with what is called Blaschko-linear distribution, which is the streaky and curvy linearly arranged verrucous papules on the trunk and the proximal part of the limb. So, on the left, you could suspect epidermolytic hyperkeratosis, but on the right, it looks like a linear verrucous epidermal nevus.
And again, very pretty appearance and a characteristic appearance on HND. You can in fact make out the reason it's called what it is called. There is epidermolysis going on here, and there is this marked hyperkeratosis. And this is in its entirety is the papule or nevus which you see. Now these nevoid conditions, some people group them as genodermatoses, are actually associated with each other. In other words, you may see a very classic epidermal nevus with this kind of a pattern, and in a epidermolytic hyperkeratosis, you may see features of an epidermal nevus. In other words, there is no epidermolysis, there is just the hyperkeratosis and acanthosis which you see in a nevus. So these are the same family of disorders, and you may see them in a mixed pattern, as Dr. Ramam pointed out in the first. This is epidermolytic hyperkeratosis.
And the traditional teaching has been that whether you take a biopsy from the ichthyotic lesion or the verrucous epidermal nevus-like lesion, you see the same picture, and that is true. But we have found that when you take a biopsy from the nevus-like presentation, then the epidermolytic hyperkeratosis shows a skip areas of normal skin. Whereas when you take it from patients with epidermolytic ichthyosis, then it's uniform across the biopsy. So that's an interesting observation that our group has made. All right, so the penultimate case for this evening. Now, this is a condition that we have hardly ever diagnosed clinically. Almost always it's a biopsy surprise for us. There are these rather nondescript papules or papulonodules on the skin. On the left, they are smaller, and some of them have central crusts. And on the right, it's again, a skin-colored, slightly larger papulonodular lesion. And we may have seen about 12 to 15 of them over the years, and I can hardly remember any situation where we made a clinical diagnosis. So I'm not going to embarrass myself by telling you all the different things that we thought when we saw this, but it was not the right diagnosis. That's all I'll say.
When you have a biopsy, of course, I'm starting off with the high power, you see that there are foam cells, and there are foam cells which contain some bodies. Very nicely you can make out in this magnification. And what are these bodies? They have a clear surrounding material and mild staining in the center. In other words, this is looking like a capsule enclosing some other structure. Each one of these materials is a capsule which is clear, and it is surrounding these material. And when you do a PS reaction, of course, here you see that the inside innermost material is positive, and the capsule again is negative. I'm sorry, I don't have the correct photo. Maybe I can show it to you guys sometime. On the silver methenamine, you can make out that this material, again, the central part is positive, the capsule is negative. And what we need to do, of course, in this is a Alcyon blue PS reaction. And Alcyon blue will beautifully stain the outside capsule, and the PS will stain the central part. It looks extremely pretty. And as Dr. Ramam said, seldom is the clinical diagnosis made unless and until there is some very, very pointed feature pointing to it. In other words, a lung infection in which the cytologists have already seen some such bodies in the sputum or something. Otherwise, to make a primary diagnosis is difficult. And at times, let me tell you, even on pathology, this has been missed. People have called it non-specific inflammation and not done the appropriate stains, and they have just missed the clinical diagnosis, the pathology diagnosis. Should we? Yeah, we are now in time. Should we go to the end, Rama?
Yes, let's do that.
Case 26 is our last case. We are skipping the cases in between.
Now, this man had recently retired from his job, and he presented to us with a widespread erythematous papular eruption. It was not itchy, but it was continuing to increase. It was continuing to develop new lesions, and that was what brought him to us. And when we looked at him, we wondered if this is sarcoidosis, or if it is some papular psoriasis, or some unusual viral exanthem that was unaccompanied by constitutional symptoms. So those were some of our thoughts when we saw this patient.
I would have thought of a sarcoid on this. But we are going to skip the regular histopathology of this and just show you some of the special stains. Now, this is something which I have tried. This stain I have tried to do a lot, and I have not succeeded. I am happy to see that Dr. Sudhir Rava has finally managed to do this. Ramam, have you ever seen this? Varistarina syphilis.
No, I haven't.
As you can make out here.
Wow, it's lovely.
As you can make out here, this fibrillary fibrous structure, this is a spirochete. Ramam and I have for many years tried to sort of see this, and we have never managed to do it. But here you make out these spirochetes, causative organism of syphilis. Again, the same thing here. Just wanted to show you this, a very pretty thing, which you see in either a primary chancre of a syphilis, and at times what people actually feel that it does not happen, but we have seen this now in secondary syphilis also. It may be there. Thank you very much. We have cut out some of the slides because Dr. Ramam I was threatening to go on for 3 or 3.5 hours, but Dr. Ramam didn't want to do that.
Yeah, I got a bit hungry.
Thank you very much.
Wow, beautiful. Thank you. Thank you.
All yours, Ramam.
Thanks. Now, some of you might be wondering what a dermatologist is doing with Dr. Manoj in a pathology department session like this one. Let me explain. Now, many years ago, like kids watching others playing a game that they want to join, we asked Dr. Manoj if he could also do some dermatopathology, see slides, discuss them. And being the person he is, he said, sure, no problem. And he let us into his department to play. And up and down the hierarchy, he let people know that we had his endorsement. He basically gave us the run of the place, unhindered access. And whenever you start something new, there is a learning curve. And for us, that learning curve was a tough and sometimes bumpy curve, but he guided us, he supported us, and he encouraged us. And on the occasions that we ran into some rough weather, he strategized and adjusted so that the collaboration was protected. And it is now 17 years that this partnership has been going on. What began with 2 people is now a larger gang. There are 4 people in my department, and Dr. Sudhir and Dr. Shipra have joined Dr. Manoj, making for a strong group. Our collaboration has strengthened teaching, research, and patient care in both our departments to the benefit of our trainees as well as our patients. Manoj told me that this may be our last JugalBandi before he superannuates. But superannuation is an organizational formality. And I really hope that we will have several other opportunities to do this again, and that the bonds that have been forged between our departments will last well beyond your superannuation or mine. Thank you very much, my friend. Thank you.
Well, I just hope that this carries on. And we have actually, for the past several years, been skipping this JugalBandi. We started this off where? Was it in Chandigarh?
Yeah, I think so.
We have also done it in Chandigarh. I don't remember which one was first. But Ramam and I have together done a lot of these JugalBandis. And in fact, in this very PowerPoint, we have 5 or 6 slides left. And we have maybe 300 or 400 cases, which we can put into a JugalBandi as and when necessary. So whenever anybody wants us, we are happy. Shipra and Sudhir, questions for us?
Yes, so hi, hello everybody. I think I cannot put on my video because, okay. So hi everybody, what is JugalBandi it was? It was, I don't know, it was a beauty for the eyes and music for the ears. So that's how I can describe it. So great. So let's go to the questions now. So the first question which we have is, can we diagnose Mycetoma without fungal culture?
Yeah, sure.
So Dr. Manoj, will you take?
Well, the important issue, as I said, is something which our clinical colleagues are seldom able to do because of shortage of time, is if you keep a clean white bandage on the lesion, on the sinuses, 72 hours to or a little longer, you may see a granule. And if you see something which is discharging granules, whether you see it as a discharge or you see it as a biopsy, you make a smear of it and you see the fungal bodies. So you don't have to do and as Dr. Ramam very, very carefully and repeatedly pointed out, the issue is to decide whether this is fungus or bacteria. And there are nice, well-defined treatment protocols for both. But you have to decide first whether it's a fungus or a bacteria. All the fungus will have the same treatment. The bacteria will have similar treatment, whatever antibiotics you're giving for a long time. But they are both eminently treatable today. You just make a smear and decide.
Can I quickly add a comment, Dr. Shipra? So I just wanted to say that fungal culture will tell you which fungus, but a biopsy is enough to tell you whether it's fungus or bacterial. And often for us, that is enough information. Thank you.
Next.
Thank you so much. Will you like to take the next question?
Yeah, one person is asked how to differentiate BT leprosy versus sarcoidosis when the biopsy does not include nerve fibers.
BT versus?
Sarcoidosis when the skin biopsy does not include nerve fibers.
Actually, that at times may be a problem. And as our mentor in leprosy, Dr. Ashok Mukherjee used to constantly show both Ramam and myself, when in a tuberculoid leprosy you have nerve involvement, which I had shown you, there are times when the nerve actually gets erased. Nerve does not exist. It has been wiped out by the inflammation and necrosis. And in that, it is important, if you do an S100 stain, as I had shown you, there is a nerve bundle, which may or may not be recognizable as a nerve bundle. And when you see the S100 stain, there are very few intact fibers. Most of it is actually fibrosis. But if you do an S100 stain on a skin biopsy, you should see some remnants of nerves, of the cutaneous nerve twigs. And if you see them, then and you see them as destroyed, then you know what you're dealing with. Otherwise, at times it may be difficult. And actually, you have no business if in a tuberculoid leprosy, if you have screened it thoroughly, and even on an HND, you will see some nerve twig or the other. If you're not, it's a very, very end stage of leprosy, where in fact you might not even see the inflammation. It might have just healed and fibrosed. Ramam, anything to add?
Well, 95% of the time, it's, you can tell them apart. But as you said, there are times when it's really tough. When it's not tough, then what helps you is not looking at the granuloma, but is looking at the distribution of the granuloma. So if it's curvilinear, following the neurovascular bundle, superficial and deep, then it's leprosy. If small granulomas, rounded or oval, huddled close to each other, then it's sarcoidosis. But as Dr. Manoj has pointed out, there are some cases of sarcoidosis where the granulomas follow a leprosy pattern, and there it can be very tough. And clinicopathologic correlation sometimes gives the answer in those cases.
Shipra?
Right. Yes, sir. So we have another question regarding actinomycosis and eumycotic mycetoma. So if the filament size is not visible, as was the case in the current actinomycotic case, how will we call it actinomycotic mycetoma?
You do not. You do not, as Dr. Ramam said several times. If you do not see a granule, if you do not see an organism, you report it as such. And you tell the clinician that we have seen multiple sections from your 3 biopsies, but we have not seen a causative organism. Then they need to biopsy it again. Because unless and until they have a proper diagnosis, they are not going to treat it.
Correct. And can I just point out again, sometimes we get a report saying that the features are compatible with actinomycotic mycetoma, but there's no grain in the biopsy. That's really unhelpful because the patient may actually be having a eumycotic mycetoma, and for months we might end up giving him the wrong treatment. Whereas if you say, as Dr. Manoj has said, that there is no grain, then at least we know we have to look further.
Sudhir?
So many people have commented that it's a very beautiful, very informative JugalBandi with very informative discussions, especially the clinical and histopathology pictures. I have one question for Professor Ramam, sir. So when you have a clinically suspected case of Pemphigus vulgaris with the oral lesions, so most of the times what difficulties we face is when the oral biopsies from oral lesion, the epidermis will be shed off. So we cannot. So what do we do in that scenario? And when what conditions you do oral biopsies?
Right. So our oral biopsies are not our first choice of biopsy in pemphigus. If a patient has both oral and skin lesions, we always prefer to take a biopsy from the skin lesion. So if a patient either had skin lesions which have healed and he's only having persistent oral lesions and the diagnosis has not been documented in the past, then we might take an oral lesion. Or if a patient has come early before the skin lesions have developed, then we take an oral biopsy. So those are the two settings in which we take oral biopsies.
Actually, as we have seen, as the recipient of these biopsies, not so much from dermatology as from the dental department, because they see an oral ulcer, they biopsy it, and many times we have actually sent back a report that this is compatible with an aphthous ulcer or whatever it is. But the only way you can differentiate these, actually, the reason you are asking this question is very simple. In the mouth, there is a lot of infection. There is moisture constantly. And as I told you, the epidermis itself is fragmenting. So there is superadded infection and maceration of the epithelium. So at times you cannot, as you rightly said, cannot make out the upper part of the blister at all. But you may be able to see that the villi or the row of tombstones in some areas. So look carefully at the basement membrane zone. If you see these, that row of tombstones, at least you can make a suggestion. Because once again, our experience with the fluorescence in oral biopsies is also not as good as it is in skin biopsies because of the superadded infection and maceration. But if you see that characteristic appearance of villi and single layer of basal layer cells which are attached to that basement membrane, then you can at least give a suggestion.
Yeah, I should add that most of the time our mucosal biopsies, you are able to tell us that it is pemphigus.
I agree. Yes.
It's important actually more in the flip scenario which I had mentioned. If you are giving a biopsy report to an oral surgeon, then you have to tell them that this is suspected pemphigus. Please show to somebody, a dermatologist, because the dentist is not going to see anything apart from the mouth, and this person might very well have lesions elsewhere.
You're right, sir. We do see these occasional cases where the biopsy comes from dental region or ENT, where they take biopsy and we suspect pemphigus vulgaris, and later on the patient will be referred to dermatology. It had happened many times.
Yes.
True. And I think many of the people from the audience, they have taken a fancy for the Mycetoma cases. So we have quite a few more. One of them is an interesting one. I think Dr. Ramam may take it. So can eumycetoma and actinomycetoma, eumycotic mycetoma and actinomycotic mycetoma coexist?
Simple answer, no.
Okay, great.
I would extend that answer a little bit. Not in our experience. It may exist.
It may exist. Agreed.
I mean, it happens in the same geographical scenario.
Yeah, 1,700 people die of lightning strikes every year in our country.
Good one.
Good question.
Any others?
Sudhir?
I think we have covered almost all the questions, sir. So,
there is another question. So, can HPV manifest as a hypopigmented patch like the one seen in the case with Epidermodysplasia verruciformis?
Can I take that? So there are times when people, present with EDV like we showed you, and then they have this picture on histopathology. But there are other times when people seem to have ordinary plain warts, and you take a biopsy and it actually shows EDV changes. So that can happen too. So normal looking warts can show an EDV-like histopathology, but that's very uncommon.
In fact, I remember having surprised Dr. Ramam 2 or 3 times in our time together when they did not suspect an HPV lesion. They were, macules and this, that, and the other was their clinical suspicion. And we saw something suspicious in the epidermal cells. And when we cut deeper sections, then we saw more of them. So we told them this is a papillomavirus, and they won't believe us. So we had to show it to them. But this has happened, that a group of macular lesions may be suspected for something else, and it may show papillomavirus lesions like this.
And one of them, I remember, Manoj, was actually suspected to have vitiligo.
Okay, so
Shipra?
yes, Shipra.
I think she's frozen. Her connection may not be.
Shipra, wake up. You went to sleep.
I think my video is lagging a bit.
Yeah, but we can hear you.
Yes, you can continue, Shipra.
Well, I am happy this has happened.
My video lagged behind.
I am happy this has happened and not in between.
In between.
Yes. So one more question. I think it's an easy one, but it's an important one. So I'll just like to put it forward. Is immunofluorescence done in the bullous lesion of Pemphigus vulgaris, or is it done on the adjacent skin?
Immunofluorescence in which Pemphigus?
Yes.
Done it in all sorts of scenarios. Actually, as I had shown you the bulla showing positivity photographs. But even if you do it from a otherwise uninvolved skin, you may see positivity. You do see positivity in an active phase of the lesion. And with Dr. Pasricha, way back many years ago, we have in fact done a series of cases where we did immunofluorescence on the zinc smears, and we found positivity in the zinc smears, thereby indicating that a biopsy may not be necessary in all cases of pemphigus. You may get by doing a fluorescence on only the zinc smears.
What we teach our residents is to take the blister for HND and perilesional skin for DIF.
Okay, any more questions, Sudhir?
I think we have covered almost all the questions. As Sir said, perilesion, even in the presentation, Dr. Manoj Sir has mentioned one DAF of Bullous pemphigoid where there was no bulla and there was beautiful basement membrane positivity. So that can perilesion in the area. That was a beautiful pictures. I think we have done. We can conclude the session, Shipra.
Yeah, thank you so much. So it was indeed a very informative discussion and with many learning points on common as well as rare diseases in the field of dermatopathology from very experienced faculty of ours. I would like to take this opportunity on behalf of the Department of Pathology, AIIMS New Delhi, to thank all our speakers, Dr. M.K. Singh and Dr. Ramam, and all the participants for making this event so successful and amazing and interesting. I really thank all the faculties in the Department of Pathology who are directly and indirectly involved in this event. Special thanks to our chairperson, Dr. Rumare, and the organizing secretaries, Drs. M.C. Sharma, Dr. Venkat, and the junior faculty, including Dr. Anjal Kakkad, Dr. Aruna Nambirajan, Dr. Kavneet Kaur, Dr. Madhu Rajeshwari, and Dr. Ruchi Rathod, who are actually the spine behind the smooth conduction of these events. Thank you, everyone, and have a great evening.
Thank you.
Thank you.
Bye.
Thank you all.
Thank you. Thank you.
We all just leave.